Okay, welcome everybody to today's lecture. We're going to be doing a deep dive into our methodology of bracket placement. There are quite a few algorithms that affect bracket placement, and we want to get into that. So I would say the main reason why we're doing this lecture today, though, is we get a fair amount of pushback from doctors. Specifically, this is that the brackets are too incisal, and it's a fair point. And we're going to get into that, and we're also going to get into 5 other points, but it comes down to this. When you compare traditional bracket placement versus being in a digital environment and placing brackets, it's somewhat limiting when it comes to traditional bracket placement. And when I say that, I'm referring to you have the patient in this chair. You need to be concerned about their comfort and time. And so there's not a ton that you can do with direct bonding with the patient there in the chair. Now, at the same time, I'm amazed at the skill of orthodontists. I mean, with bracket height gauges, obviously you've got to get the mesial distal placement of the brackets good and the angulation so that you have good tip. Doctors are very skilled at this, but in the end, there is still quite a bit of repose and a lot of wire bending. What our argument is, or our contention, or our claim, is that within a digital environment, there's quite a few more factors that you can consider, and the effect is that you're going to get much more accurate bracket placement, and thereby decrease repose and decrease wire bends. So, in fact, here's our list, some of the same ones, but there's a fair amount that we are considering, or the algorithms which make up our artificial intelligence. There's a lot it's considering before it places a bracket on a tooth, and it's all automated. But again, I want to kind of show what's happening behind the scenes so we're all on the same page. So let's kind of back up here. Let's talk about heights. So again, number one, the claim from doctors is that the brackets are too incisal. So I've got a case here within the software. I'm going to isolate this to the maxillary, and then I'm going to click 3 times on the central. Let's center it, rotate it around to the side, and kind of zoom in. I'm also going to turn on this little grid here. So if we look here, if you can see these little green lines, what the software is telling you is that from the center of the slot down the incisal edge of this upper right central, it's 4.5 millimeters. And of course, with this grid, each one of these boxes is 1 millimeter, then the dotted boxes are 0.5 millimeter. So obviously we can confirm this by counting 1, 2, 3, 4.5. That's 4.5 millimeters. Now, I've talked with orthodontists who say, yeah, that's great and all, but I'm just telling you those brackets are too incisal and it's too low. The reason for that is this. Our software is taking into consideration not just the height, but the prescription of the bracket. And in this case, this is an MBT prescription, and there's a fair amount of torque built into the bracket, and therefore that affects the outcome of the inclination of the teeth, right? So we are measuring based on a predicted outcome model, and we're not claiming that our simulations are 100%, but we certainly are claiming that measuring based on where the teeth end up overall gives you much better leveling of your teeth. In fact, if you look here, I'll come back to just the centrals. If this red line represents your occlusal plane, if you look at the cuspids in our centrals, as I rotate those around, you can see that those are right on that occlusal plane. They are perfectly level with each other because we are not just measuring straight up and down these teeth, because these teeth are at different angles. If you take in consideration where the inclination of the teeth are going to end up based on the prescription of your unique brackets, you're going to have better leveling. But still, the question remains: why do they look lower or too incisal? So again, let's zoom in here. It's all about the angle at which you measure, right? So for most doctors, you're just bringing in, say, your bracket height gauge, and you're just going to come in perpendicular to the surface of the tooth, and you're going to measure. So over here on the left side panel, we've got this little area called Measure By. If I click that drop down, you'll see I've got an option that's called perpendicular to the base. And you can see here my base now is straight up and down. And you can also see the angle at which you measure is quite a bit different the way we do it from the predicted outcome. But anyway, I'm going to click on this. When I click on it, you're going to notice this tooth drop down quite a bit. So let's click it. And there you go. Did you see that? Let's do it again. I'll go back to how we measure things. Again, taking into consideration the torque expression built into the bracket and the height itself. So here it is there, and now I drop it, and boom, there it is, quite a bit lower. That is the reason why many of our doctors say, hey, these brackets are too incisal. They are too incisal based on the way you're normally measuring, but again, it's our claim that you are more accurate. You have better accurate placement if you take in consideration where the inclination of that bracket, or where the inclination of that tooth is going to end up, and that's of course based on your prescription. All right, let's talk about the second point here in our feedback, and that is on the FA points. The feedback is that doctors feel sometimes that the placement of the brackets is not ideal in terms of those facial axis points. And again, that is a fair point and a true point. My answer to that is this. Considering the FA point is good, but within our software behind the scenes, and this is done seamlessly, automated, we're looking at a lot of different factors. So as I mentioned, yeah, the patient's in the chair, there's a few key factors you're looking at, but with the AI and with the automation, we can look at a lot of different things to get that precision bracket placement. So in the end, when you consider all these factors, you're going to have some teeth that maybe you're not where you would traditionally put it on that FA point. That might not be the best place for the placement of that bracket. And that is what we feel strongly about, is all these various ways of measuring. In fact, we have 624 tooth identifiers on a typical case. Those identifiers help us know what the long axis is for angulation. We know that we can do automatic marginal ridge alignment on those posteriors. We can have uniform occlusal contacts, tight contacts mesiodistally. We have all those things, and when you have that, you do end up with really good bracket placement, and we think that, I guess, trumps or supersedes looking at those FA points. All right, number 3, we've had doctors who they want to treat just one arch at a time. That's a perfectly valid methodology for treatment. So why would we still require both arches? So the answer to that, we have this tool here. We call it, let's get to it, uniform occlusal contacts. So this is really cool. ATA is kind of its nickname. It originally was just called automatic tooth adjustment, but really that's what it's automatically doing, is trying to get a uniform occlusion and get good contacts between the opposing arches. And I just want to illustrate this, and this is why we designed our software, and the software wants two arches, not necessarily just for this tool, for this feature, but that's how it was designed, to work with two arches. And so when you only input one scan, it doesn't necessarily know what to do with that. Our end-all be-all is precision bracket placement. And bracket placement is determined by many factors. One of those factors is getting into a good class 1 occlusion and then closing any gaps or removing any overlaps. So for example, if I turn on our occlusal collision, you can see on this case I'm hitting really hard on those 7s, while at the same time this lower 4 isn't touching anything on the up. And so what you want is a little bit of blue on each tooth. And what we used to do is you'd have to come in here and click on a tooth and pull that down so it's not hitting so hard. And what's those marginal ridges doing? Maybe you want to change the tip on that, the angulation. Oops, that's my torque. Let's get that to come down. So yeah, I mean, orthodontics is a series of compromises sometimes. So I'm totally losing that those yet nice uniform marginal ridges, but these are the 7s. It's not as critical. We've got plenty of crown. So yeah, in the old days you'd have to manually go one by one, right, and try to pull these down. But what we can do now with this tool, and again this comes all back to precision bracket placement, I'm just going to click this button, and if this picks up, if you look at these teeth, They slowly, if there was a gap, it'll close the gap. If there's an overlap, it'll remove that overlap. So now you're in a good class 1 and you have that uniform occlusal contacts, as we call them. That's a big deal. That really affects, again, even if you're only treating the upper arch, that really affects the position of those brackets. And if you look at our heights, they changed a little bit. Not so much on this model, but sometimes you'll see bigger jumps. Now there are parameters to it. We don't let the tooth go off into space forever to close a gap or to remove an overlap. But it's a powerful tool, and that affects bracket placement. So that's why we require an upper and lower arch. I'm repeating myself over and over again, but I hope you're getting the message is that we want really accurate bracket placement. And if you only have one arch, you don't have the opposing arch, you don't know what that bite's going to look like, then you can't have as accurate bracket placement as you could. So yeah, that's why we like to have both the upper, or the maxillary, and the mandibular arch. Okay, moving along here, number 4, feedback is doctors are spending 30 minutes in the software adjusting almost every bracket. So I hope from the previous things we've discussed that I'm hoping by pulling that curtain back and you understanding what the software is doing and all the factors that it is considering, that you can consider trusting our bracket placement more so than some doctors are now. It definitely should not take 30 minutes because you definitely should not be adjusting every single bracket. These last 2 questions are not necessarily dealing with bracket placement, but this is feedback that we get from doctors, not near as much as the first 3. So, and number 5 definitely is doctors that are doing their own in-house 3D printing of the transfer trays. If you pull the tray off and again the brackets look even more lower, that definitely is a red flag when it comes to 3D printing. We have a lot of literature on that to help you with it, but bottom line is if you are post-process, or if you've printed some trays and you're post-processing, we're very specific on how to do that. In fact, we're specific on the printers to use, the print resins, and how you actually do the printing and the post-processing. If those things are not done correctly, the trays is not going to fit correctly and the brackets are not going to bond in the correct spot. So for example, with post-processing, after you've after you've 3D printed a tray, it's covered in kind of a thick syrupy resin that did not cure. So you've got to make sure that the trays are cleaned really, really well. If the trays are not cleaned and you go to do your post-processing curing, it's going to cure that liquid resin down into those little areas where the teeth fit. The cuss tips are going to try to go in there, and there's going to be a hard resin cured in there. So bottom line is, look at our literature, watch our videos, make sure you're printing correctly, and really make sure you're post-processing correctly. And we're a little nervous because we've tested a lot of printers through the years. This is, printing models is one thing, but printing a semi-transparent, flexible material, the curing times, the resin, all these things are really super important. You've got to be careful on those things, but we can help you through that bottom line to make sure those brackets, or so those trays are fitting absolutely perfect over the teeth, and that the brackets are fitting absolutely perfect within the trays. This last question, we get this a lot. We're like, hey, we need step-by-step documentation. So both on the clinical side, we have a clinical training manual that has just about everything you need in there. On the digital side, we do have these lecture series. In the past, we've had a lot of documentation, and it seemed to maybe overwhelm staff and doctors because it was so much. So we've thought it's a little bit easier to digest through these lecture series where we've shown how to use the software and best practices with the software. Okay, with that covers our lecture series for today. Again, if you have any questions, feel free to reach out to us here at OrthoSelect, and we're happy to help you. Thank you.